First of all, thank you for the kind invitation. It's always nice to be here in Hyderabad, coming from sultry weather of Delhi. It was such a pleasant surprise. So, before we move on to really coronary artery disease, which is the topic, I thought, this slide should come in first. Don't think it's just coronary artery disease, but just keep it somewhere in the back of your mind. These guys have other issues, cardiomyopathy, portable pulmonary hypertension, etc. But yes, we are going to concentrate on coronary artery disease. So discussion plan is the relationship of CAD with the end-stage liver disease, risk factors, etiology, and it's changing its relationship to coronary artery disease. I think you are aware of that. What intervention? That's the gist of the topic. And safety concerns regarding coronary artery stents. Are they safe enough, good enough? How to use them? And are there any newer insights into it? So we'll go a little up and down with it, but more or less these will be things we will be discussing. This was the paper, I think, which created a lot of, chaos in the circles. 50% mortality, everybody was so worried. This was 1995 or, somewhere around that time. And, everybody was worried, coronary artery disease. Till now, the understanding was liver disease, good peripheral vasodilatation, patient can get through. Liver disease is protective. That used to be some sort of a feeling going into end-stage liver disease. But then this really, I think this is the one that woke up everybody. Look, come on, this is an issue. And then, of course, many papers started coming out. The incidence is, look at this, it's pretty high. End-stage, some people, put it in single digit, but as much as 28% in end-stage liver disease. So again, the incidence is pretty high. In our study, in our hospital study where we had a look, it's about 18%, which is quite significant. Of course, etiology is important, like I said. And etiology is changing. Now, this is the recent data. I think NASH is taken over. But I think when we started off earlier on, the important indication used to be, number one used to be hepatitis B. Then we got hold of that. Hepatitis C was always there. It's still there, but it's again coming down. Alcohol is held its place, but coronary artery disease and NASH, as we stand today, it's really on an upward curve. But do we have more knowledge about NASH? Yes, I think many studies are saying that. NASH coronary artery disease has much higher incidence. Again, it's both obstructive and non-obstructive. And what is really come out a bit more is there is probably some element of inflammation, so which we have not been looking at it critically. So this study again said NASH, if you look at it, NASH with inflammation, maybe they have more incidence of coronary artery disease. So this is a study from this part of the world only. I think it's from Tamil Nadu, published in Libyan Journal though, and they found CRP and ferritin. They had a huge correlation in patients with coronary artery disease. So NASH may be a accompaniment with it of inflammation, probably has more pointer, a greater pointer towards developing coronary artery disease. These are the typical risk factors Susan Mendel had initially proposed. Again, she also said NASH in the beginning. This is 2008, but I think they all hold good even today. And this was the cardiac evaluation protocol which she had suggested, and keeping these risk factors in mind. We'll talk a little bit about calcium score later on. Firstly, stress testing. I think whatever you might say, we've still not been able to shake off the stress testing in our assessment. Give increased stress and see this is how it is done. You can do both dobutamine and perfusion thallium scan. But what is it? Both of them have good negative predictive value to show you, whether it has got whether if they don't have a coronary artery disease, but very poor predictive value. Again, traditionally, a score of 400 is seen as a high risk of developing coronary artery disease or seeing significant obstructive lesion in the coronaries. So this is a non-invasive method. So this can be used as well. But having said that, only good predictor in this is if you have a score of 0. If you have a score of 0, then you can be rest assured patient doesn't have any significant coronary artery disease. I think beyond this, it's really a kind of a graph. So 0, good. 400, probably, these are two good endpoints. In between is variable. Again, it's looking at calcium deposits. Now, this study said more than 100 have increased chance of coronary events, and we carried out a retrospective analysis in our patients, and this is what it said. We also came to the conclusion that more than 100, at least in our subset of patients. Again, this is going back some years, 2013 to 2015. So more than 100 coronary artery calcium score, they had more incidence of cardiac mortality and complications. So I think in our subset, this is again, like I say, disease pattern has changed. We are not looking at etiology here, so maybe it might look different now. So this is what our protocol used to be. Look at the risk factors, DSC for all patients, ECG, DSC, coronary artery calcium score, risk factors more than 2, maybe do another test and see what it is. And if you have calcium score more than 2, then you probably do for conventional angiography. This is another similar algorithm, I think more or less the same, not much of a difference. So coming to the topic which we have is coronary intervention. What do we have right now? Bare metal stents, drug-eluting stents, angioplasty, and coronary artery bypass graft. I think bare metal stents are probably now going out of the way. More and more we're using drug-eluting stent. We'll talk about why a bit later. And angioplasty. Angioplasty was there, it had gone off. But again, it's all resurfacing again. We don't have enough data as of now. What they're using now is drug-coated stents to do angioplasty. So apparently, they do not cause so much of restenosis. So we are again doing angioplasties in our patient with coronary artery disease, which we had given up. So again, we have very few numbers for that right now. But then, of course, the next thing is you have to be very selective about which patient do you do coronary artery bypass graft along with your transplant. So again, indication when? Major vessels, proximal disease, 70% or more block, greater than 12.5% increase in ischemia on stress test, which could be stress thallium or some other means, or multivessel involvement. So again, this study where they carried out interventions, stenting, angioplasties, they found in this cohort, doing the interventions, the outcomes were more or less similar. This is the further evidence of from the same study. What else that has come out in coronary intervention is studying of fractional flow reserve. So what is it? This is the pressure proximal and distal to the lesion. So you see the aortic pressure and you see the pressure beyond the lesion. And they try to see this flow after giving maximum dilatation, in the sense so that if it has to increase, it will increase in different circumstances. So they use nitroglycerin or they use adenosine. Both the drugs, they can be given locally or they can be given intravenous. And they look at the pressure difference before the lesion and after the lesion. And this is the meta-analysis carried on FFR, and basically looked at a lot of studies, but 7 were included, and did find FFR guided management did lead to better, less adverse effects. So what did they say in the end? Current guidelines advise do the FFR guiding your PCI strategy, and they should be performed when you have seen the hemodynamic differences doing FFR. But again, I think this is not the final word. We still have to do more work on that. So what is the guideline? FFR is 1, that means the pressure is the same, that's fine. FFR greater than 8, again you have to be careful. But if FFR is less than 0.75, I think those are the patients, they must be intervened. So whatever you do stenting or you do CABG, that's again kind of vessels that are involved. So when to transplant after PCIs? This is the old saying, 4 to 6 weeks, bare metal stent, drug-eluting stent 6 to 12 months. But having said that, of late we have been using newer drug-eluting stents, and 4 weeks after that is good enough to 4 weeks. Drug-eluting stents, dual antiplatelets, they are good to do transplant. And obviously you are looking at strength. This is the nomogram for using bare metal and drug-eluting stent. Having said that, it's been proved in liver patients, PCI is safe. Again, very few complications in this particular study, although the platelet counts, if you look, are from 23,000 INR up to 1.5 or even 1.9. So again, it's pretty safe. Quite often they are able to go through the radial artery. And, but you must keep in mind restenosis, stent thrombosis, contrast-induced nephropathy, bleeding. They are possible. Rare are arrhythmia, dissection, distal embolization and infection, of course. Keep in mind. Again, last slide. CABG and transplant, again, not a great option. You really have to consider it carefully. We've had an experience of about 8 patients. It's not without a struggle. They stay in the hospital longer. Again, CABG has to be done first, followed by transplant. 2 patients had tracheostomy, 3 had re-exploration, and 2 out of 8 did not make it. Really, to sum it up, coronary intervention has significant implication in transplant patient. Calcium score, I think, should be a part of the normal protocol. Inflammatory markers, I think one should look at it. I think we still not, there are some indicators, but we should really look at it, especially in the patient with NASH. And FFR, I think, has a role to play in borderline cases, and really combined CABG should be reserved for very, very selected patients. Thank you.
Thank you, sir. That was a lucid presentation, but like I'm a cardiologist, so I keep seeing these patients, and this talk has, I think it has come up with so many questions which can be debated.
Yeah.
And I'll let the floor ask some questions, before I take up few later.
Yeah, thank you, sir. Nice lecture. We are facing some of the patients, ACLF type, don't have a much time, near emergency, and DSC positive and cardiologist significant stenosis, more than 70% need a stent. Thing is argument. Dual antiplate cannot be stopped at least 6 weeks, then what? So ACLF already coagulopathic. So bare metal stent versus these drug-eluting stents. Previously, our senior cardiologist used to agree for bare metal stent. Now, the present generation cardiologist says that we won't use it. I don't know. The cardiologists need to tell us because the patient will not have a time. Right. We have one case of HCC. So patient had this type of situation. So we forced to postpone surgery by doing a TACE, and we buy the time. But not all cases. ACLF type of patients with the coagulopathy as a background, I don't know what to do. You tell us.
So coming to the bare metal stents, now we don't have bare metal stents on the shelf. Yeah. They're not there in the hospital. So, and I mean, we have to look at it this way. For example, why we switched over to drug-eluting stents were the long-term outcomes of patients were better with drug-eluting stents. So we put in a bare metal stent, and then you do your transplant, and the patient comes back to you after 3 months with restenosis, right? He has a cardiac event. So we need to see the patient in total. And if you look at the antiplatelet strategies for bare metal stents, it used to be dual antiplatelets for 1 month. With the newer generation stents, we have cut it down to 3 months of dual antiplatelet therapy. And now we are doing biofreedom stents where, we have one trial which clearly showed that you can use DAP for 1 month even with drug-eluting stents. So we don't see any advantage of bare metal stents over drug-eluting stents.
No, my worry is when to stop antiplatelets, because per se liver transplant is a coagulopathic low platelets fellows, bloody surgery. So you want insisting for a dual antiplatelets.
Right.
We can, one antiplatelet like clopidogrel, we can proceed. Right. But dual antiplatelet, can we stop in 4 weeks?
Yes. So we need to give at least minimum of 4 weeks. So
I agree. I think he's absolutely right. We are now doing routinely, like you say, bare metals are not there. I think the last we used was probably 2012 or something. So we not use bare metal after that. And drug-eluting stents are there, 4 weeks, dual platelets, and then they stay on aspirin. Is that protocol you do?
Yes, yes. Yeah. This is exactly the protocol which we use. 4 weeks of dual antiplatelet therapy. So we need to be little specific with the stents which we choose.
Yeah.
So if the newest generation stents, so I mean like the biofreedom stent actually has some data, reasonably good data with 4 weeks of dual antiplatelet therapy.
Yes.
The collateral supply. Did you say collateral supply, sir? So basically, what we are looking at is the blockages which are not 100%. So collaterals develop when the vessel is complete. The collateral supply is important. For example, if the vessel is completely blocked, and if it is well collateralized, we think that those patients are relatively stable. They're stable blocks, basically. They won't usually cause problems. So whenever we understand, I mean, this again, I keep having this discussion with the surgeons. The cardiac events are 2 types. When if somebody is undergoing liver transplant and patient has some narrowing, so he can have type 1 MI or type 2 MI. So type 1 MI is where there is a plaque, 10%, 20% narrowing, which can rupture and cause a heart attack. Right? That can happen to anybody. Even you do a stress test, any stress test, any patient can develop a type 1 MI. It's very hard to predict those events. What we are looking at is basically type 2 MI, where somebody has 80% narrowing in one of the coronary vessels, and that patient has significant hypotension in the peri-op period, and then he develops MI. That is because of the demand-supply mismatch. That is what we can predict accurately with angiogram or whatever we do. So it's very hard to predict a type 1 MI. It can happen to any patient. So we do a stress test, and then we say that, in one of the slides you mentioned less than 12.5% of myocardium. Yeah. So we are a little generous. We take it as 10%. If there is more than 10% of myocardium is a jeopardy in a stress scan, then we say that, okay, this patient can deteriorate hemodynamically in the peri-op period. If the myocardium at jeopardy is less than 10%, we say, okay, there's less chance that this patient can have hemodynamic instability. Still, they can have a MI due to type 1 MI. So the question again, it comes to that, if somebody has a total occlusion with well collateralized vessel, the chance of them developing type 1 MI is less. It's not different. But the chance of developing a type 2 MI is still there. Because collateral vessels, we take it as they are equivalent to 10 to 15% of normal vessel supply. So for example, if the vessel is flowing normally, or the same vessel which is blocked with collateral supply, we say collaterals, they work like 10 to 20% of the blood supply of a normal vessel. So still they can have some myocardial injury in the peri-op period.
The other thing is, nobody has really worked out giving it less than 4 weeks. I don't think it's probably possible at this stage in the stopping dual platelets less than 4 weeks. I mean, our like liver patients, they are partly anticoagulated, anyway. But still, I don't think, we will be able to do any study giving antiplatelets for less than 4 weeks.
Yes, sir. I think this.
Yeah.
Something done, stenting or something done 10 years ago, and the cardiologists will refuse to stop their aspirin or clopidogrel at all. And we keep fighting with them, and they'll say, no, you have to take forever, in spite of them having GI bleeding, low platelet count. So how do you correct that situation?
Train the cardiologist.
Change the cardiologist, Subhash.
Right.
Yes.
I mean, most of the cardiologists are similar. So the next cardiologist also will give you the same advice probably. So changing cardiologists may not help. So this comes up with data which shows that if somebody had a cardiac event under stent put in, who is on single antiplatelet versus no antiplatelets, containing one antiplatelet is beneficial with decreased events even over long time. But in somebody who has some coagulopathy, or we say chronic stable ischemic heart disease, either stented, non-stented, who has a need for anticoagulant, we stop antiplatelets in them. We continue only anticoagulant. So probably this subset of patients is similar, where they have some coagulopathy, hepatic dysfunction, coagulopathy. So there is no wrong in stopping antiplatelets, but this is not backed by data basically.
Yeah.
See, there are some situations you can't be sacrosanct that you should always give for certain duration and other things. So you see the risk-benefit ratio and convince the patient to take for surgery. If emergency surgery is there, ALF pending, so we just can't insist on the angioplasty and this thing. You need to balance it out, which risk is at that point, and then take the clinical decision.
I totally agree. It's actually, most of the times the cardiologists won't stop the procedure. The surgeons are more worried.
I don't think so. You ask Madhu.
Sir, I just wanted to ask, suppose you have a patient who has liver disease, decompensated, there's a donor ready, and you really can't wait till you put in a stent and all those things. What will be your strategy? And you have to take him for transplant. You are doing it. So what do you do intraoperatively, postoperatively to make his
depending what kind of CAD does the patient. You still have to investigate to see the extent of, like I said, stress test is no good, really. You rarely ever find anybody stress test positive. They're all, so I think we tend to go for calcium score in all patients, except alcoholic. Alcohol liver disease doesn't give you any idea because they will always have a high calcium score. So except for alcohol liver disease, have a look at calcium score, maybe give you an idea. If the calcium scores are low, maybe one can think about yes.
One beef about the calcium score.
Yeah.
So we had looked at all of data. So if you look at all MIs, patient who with myocardial infarction come to us, nobody has high calcium score. So the calcium score, all the data is from the West basically. Our people, they develop CAD at an early age. And if you look at their calcium scores, somebody who has acute coronary events, the calcium scores are always low. So there's some problem with using calcium score. The calcium score is useful to predict events over a longer period of time. So here, when somebody is undergoing surgery, the surgeons are more worried about if the patient's going to die in the next 6 months, 3 months, 6 hours. They're worried about a shorter time span. But these calcium score and all, they predict events over a longer time span. So I don't know how useful they are to predict events in the shorter time frame.
Also, I think we also probably need to watch out for inflammatory markers. At least in liver disease patients, we should probably club it calcium score and the inflammatory markers and maybe have a look at that. I agree, only calcium score may not be on its own, but with the NASH coming in, I think, it's all dynamic. I think what you were seeing earlier, the disease pattern has changed. I mean, 15 years back, it was hepatitis B. The scenario is different. I think with the NASH, I think we are going to see quite a lot of change.
So as you are seeing these kind of patients since long,
Yeah.
and prior CAD and now CAD, how easy to manage now as compared to the prior? Because many things has changed in the last 20, 30 years, sir.
Yeah. I think you're going to see more CAD, more obstructive CAD now with the NASH coming in.
So
This is what I feel. Of course, time is going to tell.
When I say starting the critical care, then first of all, I think say the surgeons.
Yeah.
Surgeons' skill. They used to do a surgery for 15 to 18 hours.
Yeah.
Now the surgery time is 6 hours, 7 hours. Blood transfusions, products. These are the less complicating the post-operatively stress-induced cardiomyopathy and everything, sir.
I tell you what, the problem really comes in the post-op. Intra-op, rarely you will have anything. Patients are vasodilated. You're fine. Once everything is restored, vascular tone is back, that heart is going to be more stressed for the same kind of work it is doing. So I think intra-op, you'll get away. I mean, like you're saying, doing a transplant, you will probably get away with most of them, maybe 80% block also. But problem is going to come post-op when your guards are down, you think you had a successful transplant, everything is coming back, and then maybe also a few months down the line, when they do develop metabolic syndrome, earlier on they will need something doing. But if it's really a very urgent situation, yes, you can get away with significant coronary artery disease, I agree, but post-op is going to be the real problem.
So, thank you, sir.